In this masterclass, we will be discussing the practicalities of paediatric airway management. I aim to allow you to understand the principles of managing the paediatric airway and provide some tips for facing this often terrifying skill, especially in the emergency situation. I will not be showing you how to perform paediatric intubation or placement of supraglossic airway devices. This is best met by clinical practice and experience. The requirements for maintaining the paediatric airway are represented in the curriculum for anaesthesia across all levels by the Royal College of Anaesthetists, at core, intermediate and higher training. There are also requirements within the intensive care medicine curriculum, and I've based the requirements of this masterclass on these curriculum elements to enable you to meet these needs. In this session, I will provide you with an understanding on the anatomical and physiological differences between the paediatric and adult airway. We will look at the available airway equipment and discuss methods of sizing these paediatric airway devices. The anatomical differences represent a spectrum from infant through child into adolescence, and the adolescent airway is very similar to the adult. In the infant, but less so the child, the head is proportionally larger with a shorter neck, which is easily obstructed when the head is in flexion. In the child, the tongue is larger and the mandible is shorter, which increases the likelihood of obstruction of the airway by the tongue. Children tend to be nasal breathers to compensate for this. In the child, the epiglottis, as shown, is floppier and V-shaped. The vocal cords are obliquely angled. The larynx is more anterior and superior than in the adult. It lies opposite the third and fourth cervical vertebrae, whereas in the adult it lies opposite the fifth to sixth. The trachea is more flexible and has weaker soft tissue connections, making it easier to displace. Also, it should be remembered that the airway is smaller in all dimensions, which means even minor swelling, which wouldn't affect an adult, can cause obstruction, as seen in the pathologies of croup and epiglottitis. The differences, especially the increased head size and anterior nature of the larynx, must be remembered when positioning the infant for intubation. The pillow can be omitted as the larger occiput means the oropharyngeal-laryngeal axis is maintained, and use of the pillow may create excessive flexion, resulting in airway obstruction. If the infant is difficult to intubate, a rolled Inco sheet can be placed below the shoulder, as shown, to maintain head extension. This is especially useful in the neonate, who have low bodily tone and may be difficult to position, and has got me out of a number of difficult intubations in the past. In the child, the pillow can be placed beneath the head and shoulders to provide a slight ramped position, as shown here. In the adult, the pillow should be placed beneath the shoulders to provide neck flexion and head extension, as you would expect in an adult patient. I will now discuss three major paediatric airway devices: the oropharyngeal airway, or Goodell's airway, named after its inventor, the laryngeal mask airway, or the LMA, and the endotracheal tube. An oropharyngeal airway can be useful as children have a relatively larger tongue. However, their usefulness may be reduced by the fact that infants are nasal breathers. They're available in sizes 000 to size 4, which represent a 4 to 10 cm length, and should be measured from the incisor to the angle of the jaw. They should be inserted in the anatomical position to avoid damaging the delicate soft tissues, unlike in adults when they are inserted upside down and rotated. The laryngeal mask airway is a useful device in cases of difficult intubation, as it can aid in oxygenation of the patient and buy time until a backup pad is formulated. It should be inserted partially inflated to enable it to mould to the airway. The sizes are shown here. However, if you forget, they're often printed on the device themselves, allowing easier selection. The volume of air required to inflate into the cuff is also written on the device, but care should be taken once inflated to check the pressure using a suitable pressure gauge to avoid damage to the airway tissues. Endotracheal tubes are sized using the formula shown here, age in years divided by 4 plus 4. Traditionally in ages below 1 year, uncuffed tubes were used, but now micro-cuff tubes are available. These allow a leak-free securing of the airway, but you must use a size smaller than is calculated to allow for inflation of the cuff. Similarly, always have a size smaller than calculated available in case of difficult intubation. In this short video, you can see the appropriate 3-point method of securing the endotracheal tube. There is an additional video available on the portfolio website for further information about this important skill. The length of the endotracheal tube is also important, and the formulas given here can be used for both oral and nasal tubes. However, this is a guide only and will vary greatly depending on the child. Always visualize the black indicator line on the tube passing through the cords, and note the length that this happens at the gum line, as not all children have teeth. This is the appropriate length. Clinical examination is necessary to ensure bilateral air entry, because of the small distances in the paediatric airway mean that displacement is possible. For all of the above measurements, age is the most important variable, but it is also important to have a method of estimating weight, useful for calculating other variables such as breathing volumes. The two formulas are given here. Remember that paediatric population is increasing in body mass index, and this may need to be accounted for. During ventilation of the patient, a volume of 7 to 10 mL per kilo should be used. Remember that intubation in the neonate can increase the resistance to breathing by up to 16-fold, so ventilation is mandatory in small children. You may need to set a larger volume to ensure chest rise and fall and end carbon dioxide levels, due to a large dead space within the equipment relative to the patient's size. You may end up ventilating the equipment and not the patient effectively. So these are my top tips for managing the paediatric airway. Always have a range of laryngoscopes, both straight and curved blades available. A Cardiff blade, which is a hybrid of a straight and curved blade, is often a useful default option. A range of endotracheal tubes is useful, especially the size below and the size above. Intubation bougies or rigid devices may be useful in the edematous airway. Always remember that oxygenation is more important than intubation. Children, especially in neonates and infants, desaturate rapidly, so if in doubt, stop laryngoscopy and oxygenate with a face mask. In these children, desaturation is usually inevitable and may be slow to reverse, so ensure your tube position and continue ventilation with effective positive end airway pressure. Out of stream capnography, the type that does not interrupt gas flow, is more useful, as it does not withdraw large volumes of gas from the child, who themselves is only moving small volume. Always prepare a backup positioning plan, especially the INCO sheet that we showed you earlier, in case of difficult intubation. And lastly, don't forget that children have poor thermoregulation. They need to be kept warm during intubation attempts. So in this masterclass, we have looked at the major anatomical and physiological differences between the adult and child airway. I've described the appropriate airway equipment and looked at methods of sizing the available equipment. further reading, the series of continuing education in anaesthesia, critical care and pain, also now known as the BJA education articles, especially the one here by Cardwell, are excellent resources. Also, don't forget to complete the quiz on the portfolio page to test your knowledge. Thank you for watching.